Wrist pain is a frequent complaint in both clinical and everyday life, often stemming from problems with the tendons. Whether you're an athlete, a new parent, or someone who uses their hands repetitively at work, understanding the underlying causes of wrist pain is crucial. Tendon pathologies can range from mild inflammation to severe ruptures, and early recognition is key to effective treatment. In this video, we'll explore the anatomy of the wrist tendons, common disorders, and how modern imaging helps in diagnosis. Let's begin by understanding why wrist pain is so prevalent and why tendons play such a central role. Wrist is a complex joint, home to two main groups of tendons, flexors and extensors. Flexor tendons help bend your wrist and fingers, while extensor tendons straighten them. These tendons pass through tight tunnels and compartments, making them vulnerable to injury and inflammation. The balance between these groups allows for the intricate movements our hands perform daily. Knowing the difference between flexors and extensors is the first step in understanding wrist function and the potential for tendon disorders. Extensor tendons of the wrist are organized into 6 dorsal compartments, each containing specific tendons. These compartments are held in place by the extensor retinaculum, a strong fibrous band. For example, the first compartment contains the abductor pollicis longus and extensor pollicis brevis, while the sixth houses the extensor carpi ulnaris. This compartmentalization is important for both normal function and understanding where pathologies can occur. Let's take a closer look at how these compartments are structured and why they matter. Anatomical variants are common in wrist tendons and can sometimes mimic disease. For example, the abductor pollicis longus tendon often has multiple bundles. Up to 9 have been described. This is a normal variant, not a sign of tendon splitting. Similarly, a centrally increased signal in the extensor carpi ulnaris tendon is usually due to fibrovascular tissue, not pathology. Recognizing these variants is crucial for accurate diagnosis and avoiding unnecessary treatment. Ultrasound has become a routine tool for evaluating wrist tendons. It's non-invasive, portable, and provides real-time dynamic assessment. High-frequency probes offer excellent spatial resolution, making it possible to see even subtle changes in tendon structure. Ultrasound can detect thickening, fluid, and blood flow changes, which are important in diagnosing conditions like tenosynovitis. Its ability to compare both wrists side by side is especially useful in clinical practice. Magnetic resonance imaging, or MRI, is the gold standard for tendon assessment. It provides high-contrast, cross-sectional images in any plane, allowing detailed visualization of soft tissues, cartilage, and bone. MRI is particularly sensitive for detecting early inflammatory changes, such as in rheumatoid arthritis, and can reveal bone marrow edema not visible on ultrasound. Advanced MRI techniques, like ultrashort echo time, are being developed to further improve tendon imaging. Decurving tenosynovitis is a common overuse injury affecting the first dorsal extensor compartment, specifically the abductor pollicis longus and extensor pollicis brevis tendons. It often occurs in new mothers, athletes, or anyone performing repetitive thumb movements. Symptoms include pain on the thumb side of the wrist, swelling, and difficulty moving the thumb. Diagnosis is usually clinical, but imaging can confirm thickening of the retinaculum and tendon sheath, as well as fluid accumulation. Finkelstein test is a classic clinical maneuver for diagnosing de Quervain's disease. Imaging, especially ultrasound, can show thickening of the retinaculum and increased blood flow in the tendon sheath. MRI may reveal more subtle changes, such as mild swelling or even tendon splitting in severe cases. Recognizing these findings helps guide treatment, which often starts with rest, splinting, and sometimes corticosteroid injections. Proximal intersection syndrome occurs where the tendons of the first dorsal compartment cross over those of the second compartment, about 4 to 8 centimeters above Lister's tubercle. It's often seen in athletes or workers who perform repetitive wrist movements. Symptoms include pain and swelling just above the wrist, sometimes with a squeaking sensation during movement. Imaging shows fluid and edema around the intersecting tendons, confirming the diagnosis. Distal intersection syndrome is less common and occurs where the extensor pollicis longus tendon crosses over the second compartment tendons, just below Lister's tubercle. It can mimic other wrist conditions, such as osteoarthritis or ganglion cysts. Imaging reveals fluid and edema at the crossing point, and sometimes thickening or partial tears of the involved tendons. Most cases respond to conservative treatment, but severe cases may require surgery. Rupture of the extensor pollicis longus, EPL, tendon is a well-known complication after distal radius fractures. It typically occurs several weeks after injury, often due to poor blood supply or mechanical irritation from fracture fragments. Imaging shows discontinuity of the tendon, retraction of the stumps, and fluid in the gap. Early detection is important, as untreated ruptures can lead to permanent loss of thumb extension. Extensor carpi ulnaris, ECU, tendon is stabilized by a subsheath at the wrist. Injury or rupture of this subsheath can lead to dislocation or subluxation of the ECU tendon, especially during wrist rotation. This is often seen in athletes playing tennis or golf. Ultrasound is the preferred imaging method, as it can dynamically assess tendon stability. MRI may show associated edema or hemorrhage, but dynamic instability is best seen with ultrasound. There are three main patterns of ECU subsheath disruption: ulnar rupture, radial rupture, and periosteal detachment. Each leads to different positions of the tendon during wrist movement. Recognizing these patterns is important for planning treatment, as some may require surgical repair. Dynamic ultrasound can help distinguish between these types by visualizing tendon movement in real time. Most flexor tendons of the wrist pass through the carpal tunnel, a narrow passageway formed by the flexor retinaculum. This tunnel also contains the median nerve, making it a common site for nerve compression and tendon disorders. Some flexor tendons, like the flexor carpi ulnaris and palmaris longus, run outside the tunnel. Understanding this anatomy is essential for diagnosing conditions like carpal tunnel syndrome and flexor tendon injuries. Flexor carpi radialis, FCR, tendon runs close to the scaphoid and trapezium bones, making it vulnerable to injury from bone irregularities or arthritis. FCR tendinopathy can present as pain on the palm side of the wrist, sometimes with swelling or weakness. Imaging, especially MRI, can reveal partial or complete tears, as well as associated joint degeneration. Early recognition and management are important to prevent chronic pain. Flexor tendon ruptures can occur due to trauma, such as knife injuries, or after surgical procedures like volar plating for wrist fractures. The flexor pollicis longus is the most commonly ruptured flexor tendon. Imaging shows discontinuity of the tendon, retraction, and sometimes fluid in the gap. Prompt diagnosis is crucial, as delayed treatment can result in permanent loss of finger or thumb movement. In some people, the lumbrical muscles, which usually arise just beyond the carpal tunnel, can be found within the tunnel itself. This variant occurs in about 22% of individuals and can contribute to carpal tunnel syndrome by crowding the space and compressing the median nerve. Recognizing this variant on imaging can help explain symptoms and guide treatment. Rarely, accessory muscles like the flexor carpi radialis brevis can be present in the wrist. These can cause atypical intersection syndromes, where the accessory muscle crosses and irritates other tendons. Imaging is essential for identifying these rare variants, which may require different treatment approaches compared to more common tendon disorders. Chronic inflammatory diseases like rheumatoid arthritis, RA, frequently affect the wrist tendons, leading to tenosynovitis and, in severe cases, tendon rupture. RA targets the synovial tissue, causing swelling, pain, and sometimes bone erosion. Imaging, especially MRI and ultrasound, is vital for early detection, monitoring disease progression, and guiding treatment decisions. Tenosynovitis in RA is seen as thickened tendon sheaths, increased fluid, and sometimes contrast enhancement on MRI. Ultrasound may show hypoechoic or anechoic tissue around tendons, often with increased blood flow. Early detection of tenosynovitis is important, as it can precede joint damage and predict more severe disease progression. Gout can affect wrist tendons by depositing uric acid crystals, leading to tenosynovitis and even tendon ruptures. Ultrasound reveals hyperechoic deposits with shadowing, while MRI shows variable signal intensities. Dual-energy CT can specifically identify urate crystals, helping confirm the diagnosis. Recognizing gouty involvement is important for targeted therapy. Psoriatic arthritis, like RA, can cause inflammatory changes in wrist tendons. However, flexor tendons are more commonly affected in psoriatic arthritis, while extensor tendons are more often involved in RA. Imaging helps differentiate between these conditions and guides appropriate treatment strategies. Calcific tendinitis, though more common in the shoulder, can also affect wrist tendons, especially the flexor carpi ulnaris. Calcium deposits cause acute inflammation, pain, and sometimes partial tendon tears. Imaging is crucial to distinguish this from infection, as treatment approaches differ significantly. Radiographs show cloud-like calcifications, while ultrasound and MRI reveal the extent of inflammation and tendon involvement. Dual-energy computed tomography, DECT, is a specialized imaging technique that can identify urate crystals in gout by using different photon energies. This allows for color-coded mapping of crystal deposits, providing a clear diagnosis when other imaging is inconclusive. DECT is especially useful in complex cases where gout is suspected, but not confirmed by traditional methods. Both ultrasound and MRI are essential tools for assessing wrist tendons. Ultrasound excels in dynamic, real-time evaluation and is widely available, while MRI offers superior soft tissue contrast and is the reference standard for many tendon pathologies. Dual-energy CT and radiographs have specific roles in certain conditions like gout and calcific tendinitis. Choosing the right imaging modality depends on the clinical question and suspected pathology. Awareness of normal anatomical variants, such as multiple tendon bundles or central signals in the ECU tendon, is vital to avoid misdiagnosis. These features can easily be mistaken for pathology, leading to unnecessary interventions. Careful correlation of clinical findings with imaging results ensures accurate diagnosis and optimal patient care. Most tendon disorders of the wrist are initially managed conservatively with rest, splinting, and sometimes corticosteroid injections. Physical therapy plays a key role in recovery. Surgery is reserved for cases where conservative treatment fails or in the presence of complete tendon ruptures. Accurate diagnosis and early intervention are crucial for optimal outcomes. Rehabilitation focuses on restoring strength, flexibility, and function to the wrist and hand. Preventive strategies include ergonomic adjustments, proper technique during activities, and early recognition of symptoms. For those at risk, such as athletes or workers with repetitive hand use, education and regular monitoring can help prevent tendon injuries. Advances in imaging technology, such as ultrashort echo time MRI and improved ultrasound probes, are enhancing our ability to detect and characterize tendon disorders. Research continues into new modalities and techniques that may provide even greater accuracy and earlier diagnosis. Staying updated with these developments is important for clinicians and patients alike. Understanding the anatomy and common disorders of wrist tendons is essential for accurate diagnosis and effective treatment. Both ultrasound and MRI play vital roles in assessment, while awareness of anatomical variants helps avoid pitfalls. Early recognition and intervention can prevent long-term disability and improve quality of life for those affected by wrist tendon disorders.